tiene un rol bastante importante. Las cartillas de manejo y seguimiento de enfermedad crónica tanto para el primer nivel como para el nivel 3, ya en pacientes sin prediálisis también, por lo que materiales educativos para el primer nivel de atención, rotafolios, los módulos de capacitación a promotores educadores pares, que es la participación de la comunidad, los videos, cartillas, ¿no? que actualmente están siendo, hoy son bastante utilizadas, la verdad, inclusive se exige mayor producción de material educativo, pero solo hasta la fecha hemos logrado hacer materiales y ya están exigiendo hacer otro tipo de materiales, ¿no? Se han propuesto también los procedimientos que debe hacer la enfermera en el primer nivel de atención, tanto en la primera atención como en las atenciones de seguimiento, los formatos respectivos de seguimiento y control. Y bueno, en las segundas funciones o actividades que hacemos, por ejemplo, el fortalecimiento de capacidades en salud renal de los profesionales de enfermería, nosotros participamos hemos realizado macrotalleres en los cuales nosotros difundimos o hemos difundido todo el material técnico normativo en todas las redes a nivel del país, ¿no? Igual, al proponer herramientas para promocionar la salud renal, sobre todo para poder empoderar al paciente, se han elaborado el programa educativo que enfoca bastante o aborda mucho la educación terapéutica en pacientes crónicos, atención de enfermería centrada en el paciente, buscando el empoderamiento en el manejo y control de la enfermedad. Tenemos acá fotos, cortesía de las redes, ¿no? Quienes promocionan la salud. Tenemos los escenarios centros educativos, maestros y estudiantes a nivel nacional, anualmente, no solo por la campaña del Día Mundial del Riñón, sino también durante el año vienen realizando actividades para promocionar la salud. Todas son actividades que en el Centro Nacional se han propuesto, ¿no? Con participación de las redes, ¿no? Cada año, como ustedes saben, se realiza el Día Mundial del Riñón en el mes de marzo, se hacen cartillas, miren, para cada año, con cada mensaje, como iniciativa a nivel mundial de la Kidney Foundation, ¿no? Entonces nosotros nos acogemos a esa iniciativa mundial y también replicamos los mensajes y los difundimos en las campañas del Día Mundial del Riñón. Son como 11 campañas desde el año 2009 hasta la fecha que venimos realizando y haciendo materiales educativos, ¿no? Y bueno, participamos en monitoreo de los procesos de estrategias de prevención en el primer nivel de atención con los equipos interdisciplinarios, se hacen asistencias técnicas, reuniones de gestión en las redes y evaluación de los procesos de prevención en el primer nivel de atención, ¿no? Como lo dice el doctor Luna, visitamos a nivel nacional a otras partes del país. Últimamente nos fuimos a Arequipa para poder dar asistencia técnica en el primer nivel de atención, sobre todo. Analizamos e interpretamos información, como es el BISARE, que muchos de ustedes seguro ya lo conocen. Hemos sacado 3 reportes, estamos en todo el sacar el reporte 2017-2018. Y bueno, en realidad, en síntesis, ¿no? Esa es toda la actividad que se hace a nivel operativo, a nivel nacional en el tema del primer nivel. Bueno, con esta presentación esperamos haberlas motivado con el tema, ¿no? Muchísimas gracias.
Agradecemos a la licenciada Huanca y la despedimos con un propio aplauso.
Parece nada más.
Bueno, a continuación vamos a tratar de cumplir la programación. A continuación tenemos la participación del doctor Tomoshima, es un médico familiar, es del Centro Médico Metodista de Charlton, entonces el programa de medicina familiar en Dallas. Él viene de una campaña bastante azarosa, como ya dijeron temprano, encabezada por el doctor Pablo Luceda. Con un buen grupo de profesionales médicos, enfermeros.
Effort to prevent kidney disease from happening in the first place so that we reduce that number. So this is what I'm going to first talk about, the definition of what chronic kidney disease is, and then why it's so important. I'm going to talk a little bit about the staging of chronic kidney disease, the screening, how we screen in the United States specifically, how we screen for chronic kidney disease, and the treatment. And again, like I said, a lot of what I'm going to show you on the slides have already been mentioned in previous slides, in previous lectures. So what is the definition of chronic kidney disease? Kidney disease, chronic kidney disease is an abnormality of kidney structure or function present for at least 3 months duration or more, with the implications for health. And it usually starts with a decreased GFR of less than 60, and also includes injury or damage to the kidney, either development of albuminary cysts or stones. The etiology of chronic kidney disease, as you heard before, is that probably the number one cause of development of chronic kidney disease is diabetes worldwide. In addition to that, hypertension and cardiovascular disease also play a significant role in the development of chronic kidney disease, as well as heart failure. And again, majority, 80% of patients with chronic kidney disease have one of these 4 factors involved, or other chronic conditions. Others being, as I said, kidney stones and other renal complications or chronic renal conditions. So why is chronic kidney disease so important? Why do we want to talk about this today? In 2010, approximately, this is data from the World Health Organization and the Pan American Health Organization. In 2010, approximately 2.3 to 7.1 million people with end-stage renal disease died worldwide without access to chronic dialysis, and 1.7 million people are thought to die from acute kidney disease. In total, acute and chronic kidney disease and end-stage renal disease, the statistics are about 5 to 10 million people die worldwide annually with kidney disease. And then but even though we have those numbers, that's not a true indication of how prevalent that is worldwide, because there are countries that don't provide data, so we don't know the true number, but that number is probably underestimated across the world. So the World Health Organization feels, as Dr. Silverman said, is that chronic kidney disease carries a threefold higher risk of death, and it's mostly due to an aging population, because in the aging population you have an increased prevalence of diabetes, hypertension, that will increase chronic kidney disease as these patients get older. Our patient population worldwide is getting older, and so they have, with that increase in diabetes and hypertension, so increases the risk of chronic kidney disease. So what does that mean economically to the countries that worldwide? Higher income countries spend about 2 to 3% of their whole annual healthcare budget to the treatment of end-stage kidney disease, even though only about 0.03% of the patients in that population in developed countries kidney or end-stage kidney disease, so that they spend about 2 to 3% of their total annual healthcare budget. In 2010, for example, 2.62 million people received dialysis worldwide, and the need for dialysis is projected to double by the year 2020. I think a lot of the slides that you saw before were also showed that data. So this is going to be an increasing problem as the years go on. So we need to address it now so that we we reduce the economic burden worldwide. In higher income countries, a lower socioeconomic status, meaning the poorer the population that you have, the greater risk that they have of developing kidney disease. So that is probably the number one factor in treatment of or in development of chronic kidney disease that's non-medical, and is that their socioeconomic status. And there's a number of reasons why that occurs, and we're going to talk about that in just a second. In the United States and Russia and England, higher income countries, also the lower socioeconomic status means that there's a reduction in access of care to those patients. They don't have the means of paying to get to the clinics where they need to go, or get to the hospital, or they don't have access to care in general. They don't have transportation to get there. So the reason that they develop chronic kidney disease in that lower socioeconomic status population is because they have less access to the care. In the lower and mid-income countries, poverty-related kidney disease is even greater than in developed countries. And the reason for that is because of associated infections, increase in hazardous work environment, poor education, and poor maternal health. All of those factors in lower to middle income countries increase the risk of developing chronic kidney disease as a result. Again, poverty. Poverty is huge worldwide. Poverty is not exclusive of developing countries. We have poverty in the United States. We have poverty all over the world, even higher developed countries. But it's the poverty causes lack of social protection, lack of transportation, poor housing, and unemployment, which all leads to factors of not getting the care that these patients need for chronic kidney disease. So again, poverty and lower socioeconomic status are both independent risk factors for development of chronic kidney disease. And the low-income countries, the reason that occurs is because the treatment costs have to be paid directly by the patients. And in many countries, a month's supply of essential medications for the treatment of chronic kidney disease costs up to 18 days out of the month, 18 days wages. So 18 out of 30 days, these patients are paying solely for their treatment of chronic disease issues. And so they only have 12 days wages at the most, 12 days wages left to be able to pay for essential things such as food and water. So the out-of-pocket costs of dialysis as well for acute kidney injury or end-stage kidney disease are even higher. So there's no way that that patients with lower socioeconomic status are going to be able to pay for this, and we have to address this as a healthcare priority. One example that I just put up here is South Africa. South Africa has limited access to dialysis and is mostly limited to being government funded. But even those that have the ability to get government funded dialysis, they're declined access because of their socioeconomic circumstances. And for those that do get dialysis, the reason that the financial burden is made worse because then they can't be employed while they're on dialysis. And so they have unemployment, or they have no means of paying for for the dialysis that they're receiving, or even paying for transportation to and from the dialysis centers. So that is a huge, huge problem, not just in South Africa, but worldwide. Nutrition in kidney disease. This was also mentioned by several of the other speakers before, is that undernutrition and overnutrition, not just malnutrition, but overnutrition, metabolic syndrome, is a huge risk factor for development of kidney disease. Malnutrition predisposes young children to infections, which can directly impact the kidney's function, and obesity increases the lifetime risk of end-stage kidney disease. Even non-medical problems can cause increase of burden on kidney disease. Climate change and deforestation, both of those increase the incidence of heat-related illness and infectious diseases, as well as pollution. People in areas that have undergone climate change and deforestation have increased contact with vector-borne illness or waterborne illnesses that can directly cause kidney disease. Examples of these are dengue fever, leishmaniasis, leptospirosis, malaria, schistosomatiasis, trypanosomas, and yellow fever. All of those directly impact the kidney, and so if those occur because of deforestation or climate change, you're going to have problems with the kidneys. End-stage leads in transplantation. Again, as it's been well mentioned, is that access to transplantation is even more inequitable. There's cultural factors, financial factors, legislative barriers. It's very political, as you know, the panel talked about as well. And there's infrastructural limitations. Even one of the problems that we have is well documented in the United States is that patients with lower socioeconomic status the African American population in the United States has a delay in the referral process of getting patients to see nephrologists earlier in their disease process, and then which then causes potentially worsening of the chronic kidney disease to the point where they end up developing end-stage renal disease. So this is just another cartoon graph of worldwide the impact on global mortality of chronic kidney disease. Again, 1 in 57 deaths worldwide are due to patients die with chronic kidney disease, and not maybe as a direct result of the chronic kidney disease, but as an indirect result of chronic kidney disease. Here was an interesting statistic, a graph that I found when I was researching for this talk, is that Peru actually has one of the higher mortality rates, and as this is, I believe, was in 2007. It showed Peru just below Nicaragua and El Salvador as the higher mortality rate due to chronic kidney disease and renal failure, which was an interesting statistic that I found. So why should we look for chronic kidney disease? Again, chronic kidney disease can affect many, many other organs. And we have to be vigilant on trying to reverse the worsening of chronic kidney disease so that we don't put increased stress on other organ systems. This graph here shows you the clinical manifestations of what other organs can be affected by chronic kidney disease. You have cardiovascular problems. Dr. Silverman talked about high blood pressure, increased heart rate, dysrhythmias. The immune system increases chronic kidney disease, predisposes the patients developing increased risk of infections. Musculoskeletal, decreased calcium and vitamin D impairment, blood, hematological problems, neurologic problems. You can see the whole graph. Every organ system can be affected by chronic kidney disease, and that's why it's so important to treat and prevent. So why should we look again for chronic kidney disease? If it's detected early, you can prevent complications and to delay the progression of kidney disease. Factors that lead to progression of kidney disease, such as cardiovascular disease, diabetes, hypertension, heart failure, are overlapping to a large extent. So if you can prevent one, you can hopefully reduce the progression of that other disease as well. So you want to target those risk factors that are modifiable in reducing cardiovascular disease in people with chronic kidney disease to reduce progression of chronic kidney disease and to end-stage renal disease. So one of the things that I like is that chronic, and the next couple of slides show this, is that chronic kidney disease and end-stage renal disease doesn't just affect the patients as well, okay? It infects the whole, the environment. What I'm talking about, that for every 2 million people that are requiring dialysis, and remember there's millions and millions of patients worldwide that are getting dialysis. For every 2 million, it requires 160 billion liters of water just to dialyze those patients. And it generates over 900,000 tons of predominantly plastic waste that are developed as a result of that. So it's not an impact just on the patient and the healthcare system, but it's an impact on the environment as well. So how can we reduce this footprint on the environment caused by end-stage renal disease and dialysis? We can try and clean local product and create local product production of dialysis supplies. reprocessing of dialysis filters, the reuse of dialysis water, solar-powered dialysis, as well as waterless dialysis. Those are things that we want to try and do to decrease, again, that footprint on the environment. So how do we classify in the stages of end-stage renal disease? Staging is recommended that chronic kidney disease based on the cause, the GFR, and the albuminuria. You can do many different tests, including urine, serum creatinine, and other blood tests, as well as ultrasound and CT scan, but the staging usually requires you looking at the GFR and the albuminuria. This is one of the more recent recommendations. You've heard a lot of talks this morning about stage 1 through stage 5. A lot of organizations are actually splitting stage 3 into stage 3A, stage 3B, which you can see here. Not just a single stage 3, because of the fact that you have stage 3, which represents a GFR between 45 to 59, and stage 3B, which represents GFR between 30 and 44. They're finding that there are a lot of differences between those two, and you can't combine those two levels of chronic kidney disease together. And so there's a lot of the National Kidney Foundation, for example, and the World Health Organization are trying to promote use of not just the stage 1 through 5, but stage 1 through 5 with a division of the 3A and 3B. And then there's also they're also trying to combine that with the albuminuria levels and the absolute creatinine ratio in approximate equivalence to help us better assess the risk of patients developing chronic kidney disease. So this is the slide that kind of shows that, is that patients with stage 1 through 5 with the division of 3A, as well as the persistent albuminuria, the higher persistent of albuminuria, increase in albuminuria, together with the stages, increases your risk of developing or prognosis of a chronic kidney disease. So we want to try and keep them from going down, not only reduce them from going to G1 to G5, but you also want to reduce albuminuria as well, so that you reduce their prognosis. So we talked about screenings. Again, previous talks have said that in the United States, the American Diabetes Association recommends that all patients with diabetes be screened annually for CKD. The National Kidney Foundation recommends annual screening as well. In addition to that, JNC8, which is the Joint National Committee, the date time that they've met, which developed guidelines on hypertension, recommends annual CKD screening as well as the American Heart Association recommends annual screening for patients with cardiovascular disease, screening for an annual basis. So who do we try and screen for albuminuria? Primary prevention recommend screens. Usually the ones that we're going to screen for albuminuria include diabetes, hypertension patients, and the elderly. Now, again, CKD staging is never part of the staging. You need to repeat the tests annually in diabetics and every 2 to 3 years in non-diabetics. So how do we treat? Again, sometimes it means treating the underlying conditions that cause the development of CKD in the first place. And that's the goal, is to prevent the patients from progression to CKD or end-stage renal disease, to prevent complications such as cardiovascular disease and death. And you want to develop a global risk assessment as well as treatment. One of the main state treatments right now that used to treat CKD is ACE inhibitors or ARBs. And then we also want to try and reduce the global risk, such as maintaining good glycemic control and treating cardiovascular risk factors. In addition, lifestyle recommendations, we want them to at least try and encourage them to do aerobic physical activity at least 30 minutes 5 times a week, reduce their salt intake, and reduce the protein intake, limiting it to 0.8 grams per kilogram per day in adults with a GFR less than 30, and avoid high protein intake in adults with CKD at the risk of progression. Treatment of blood pressure control or maintaining patients' blood pressure in CKD patients. The KD-IGO is the kidney disease improving global outcomes that was promoted and developed and promoted by the World Health Organization. Suggests that systolic blood pressure of less than 130/80. In addition to that, the American Diabetes Association as well as Joint JNCA recommending systolic blood pressures of less than 140. Again, which meds? As I said before, the ACE and the ARB therapy should be used in all patients with CKD. And then the kidney disease, improving global outcomes, World Health Organization data suggests that ACE and ARBs are only necessary if their albumin-creatinine ratio is greater than 30. What about diabetes? Again, it's the leading cause of CKD worldwide. Diabetic nephropathy occurs in about 25-40% of the patients with type 1 or type 2 diabetes within 20 to 25 years of disease onset. So you want to make sure that they have a hemoglobin A1C of approximately 7.0% to delay or prevent or delay the progression of complications, microvascular complications, and kidney disease.